All right, good evening, everyone. I'm Dr. Michael Twyman, the biohacking cardiologist. Tonight's going to be about LP little a. So this is the third installment of Lipids 101. So for my previous two videos, those are on the Instagram TV channel and also on my YouTube channel, Dr. Michael Twyman. So week one was all about lipids, just what are lipids, what is cholesterol, what are triglycerides, how do those get transported around the system and the different lipoproteins, the like little ball carriers that transport the things around in your bloodstream. Week two was all about treatment options. So, if you're somebody who's already had a heart attack, stroke, bypass surgery, there may be certain pharmaceutical options that you should consider to reduce your risk of having a second event. If you've never had an event and your calcium score is 0 and you're low risk, there's different lifestyle things and maybe potential supplements to consider. But tonight we're going to be talking about LP little a, or lipoprotein little a. So this is a particle that is very similar to LDL, but it has something else attached to it. And LP little a, which is always somewhat complicated to say, is something that looks like this. So the LDL particle, is filled up full of cholesterol and triglycerides. On the outside of the LDL particle, there's something called apolipoprotein B. Just lets the body recognize that type of particle. But what LP little a is an LDL particle, and an ApoA basically attaches to the ApoB part of it. The body doesn't recognize that as well. LP little a is very atherogenic and thrombogenic. What that means in layman terms is it's more likely to cause plaque in your arteries. It's more likely to cause clots in your arteries as well. So how does it do that? And why does it do that? But first off, a little bit of history about what LP little a does. So 20% of the population has LP little a. So it wasn't there, just because, it's something that is there to give you a heart attack or stroke. It was there to help you with not bleeding to death. So, 20,000 years ago, when the caveman's out there hunting in the morning time, if he gets injured, he was much more likely to bleed to death than he was to clot to death. And LP little a was thought as one of those things that would prevent bleeding. LP little a is very similar to something called the plasminogen. Plasminogen and LP little a look, they're homologs. They basically look the same. But plasminogen helps keep the blood thin. LP little a makes the blood more sticky, more likely to clot. The other thing that LP little a does that's a little bit different is that it's basically like a garbage truck scavenger. It's going around the bloodstream, picking up different oxidized moieties, different oxidized phospholipids. So like a dump truck, it picks up this stuff, and it's not 100% known exactly where the LP little a is cleared from, but it's likely taking it back to the liver to try to get rid of it. But if the LP little a gets stuck into the walls of the artery, then it's going to damage, all this little damaged trash that's inside of it. Now it's stuck in the wall of the artery. Your body's going to see that as a bacteria or an infection, send out the immune system, and start attacking this stuff. So you don't want to have LP little a invading the walls of your artery. So how does it invade your artery? It's when you have endothelial dysfunction. The endothelium is the inner lining of your blood vessels. It's one cell thick. The endothelium, if you took out all of it, the surface area of it would be 6 tennis courts. The endothelium releases nitric oxide to dilate the blood vessels. Also, somewhat acts like Teflon to prevent stuff from sticking to the arteries. So if the endothelium is damaged, LP little a, it's not exactly like leaky gut, but LP little a can then bind to these different lysine binding sites, and then it gets stuck under there. You can test your nitric oxide levels with different types of test strips. We have these available in my office at Apollo Cardiology. There's also a test called an EndoPAT, which is non-invasive, pretty much the gold standard non-invasive way to tell you how healthy your arteries are by releasing nitric oxide. So if you have abnormal endothelial dysfunction and you have LP little a can get stuck in the arteries. And this is very likely what triggered the event for Bob Harper at age 52. Bob Harper was the gentleman from The Biggest Loser. He had a heart attack while working on the gym, had bystander CPR, was successfully resuscitated, went to the cath lab, got stented up, and recovered. But his near-death experience was very likely to LP little a. He looked very healthy on the outside. I don't know exactly, if he'd ever had carotid endomedial thickness scans or calcium scores looking at his heart arteries, not likely. But if he did, he would have known he was at higher risk. And so that's why, my practice, I learned from some very wise mentors, test, don't guess. Just looking at somebody on the outside, you don't know how healthy they are on the inside. So if you do some type of imaging and find a bunch of plaque that you're not expecting, LPLA often is one of the contributors to it, especially if somebody's had a heart attack or stroke in their 40s or 50s or has a family member that does that. So LPLA is a blood test. It's not done on the traditional lipid panel, so you have to ask your doctor to check it. But you really only need to check it one time in your life initially. Who should get it checked? Likely everybody, but anybody who's had a heart attack or stroke at an earlier age, or has a family member that has, or they have an abnormal CT coronary calcium score, or they have an abnormal carotid endometrial thickness test, LPLA should be ruled out. The values where they're considered abnormal, there's differences. There's the mass or the concentration. The concentration of LPLA is more important. So that'd be measured in something called nanomoles per liter. And it's debatable which is considered completely abnormal, but over 75, the risk starts increasing. And then typically over 125, that's really where the risk is high. And I've had people with numbers in the 600s before. And that comes down to the differences in something called the Kringle repeats. So on the outside of this LPLA, there's this little thing that looks like a corkscrew. The longer the corkscrew, the bigger it is, the less copies you actually end up making. If you only make real short corkscrews, your body can kind of churn out more of those things, and you'll have a very high level of LPLA by concentration. And you get one of these LPLA genes from your mom, one from your dad. Everybody has a little bit of LPA in their blood, but it's the level that is important. And sometimes if people inherit 2 copies of the small from mom and dad, they'll have excessively high levels of this LPLA. And those are people who are much more likely to have early heart attacks and strokes. So that's the main concern with LPLA, is it increases your risk of heart attack by 3 to 4 times over the general population. It also increases valvular aortic stenosis. The aortic valve is the valve that lets the blood flow out of your heart every time it squeezes. So people who have LPLA, it tends to calcify that valve. And so instead of opening up like a big triangle, it opens up like a small hole, and it's much harder for the blood to get out. The valve will ultimately wear out, and the valve will probably need to be replaced. And so anybody who has high LPLA, they should have their doctor listen to their chest and see, do they hear a murmur? If they hear abnormal flow, it can be that valve is starting to get stenosed or closed. So an ultrasound or echocardiogram, take a probe, take some pictures of the heart, make sure that valve is opening appropriately and that the flow across it is normal. So that's what LPLA is, and that what is the major risk: heart attacks, strokes, and calcifying aortic valves. Those are the 3 main things. So what do you do if you have LPLA? That's kind of the $1 million question. Bottom line, there are not great treatment options for LPLA at this time. There are drugs and trials that may be beneficial, but those are many years down the road, and we'll talk about those in just a moment. So, I talked about last week, the benefits of statin therapy for patients who've had heart attacks, stents, strokes, bypass. Statins do not affect LPLA in a positive way. And in some studies, it actually shows that LPLA levels go up on statins. There's thoughts that, how does LPLA get out of the body? Maybe it is the LDL receptor. The LDL receptor is that little catcher's mitt that sits inside the liver, and then when that LDL particle with ApoB on the outside of it is seen in there, it pulls it in there. Well, sometimes that LPLA particle might be able to fit in that receptor and be pulled down too, but it may not fit it nearly as well as normal LDL particles. So, statins make that receptor stick out longer, but in most trials, the statins do not lower LPLA. It actually may increase it a little bit. But would you still use the statin in somebody with LPLA? Yes, because what are the goals? Try to get LDL particle number as low as possible so that there's less things going around in the system banging the walls of the artery. Most of your ApoB containing particles are still going to be LDL, but if you pull that down, maybe there's less damage to the endothelium. There's less for LPLA to get stuck in and start causing its damage. Also, statins have the benefit of lowering, high sensitivity CRP, lowering inflammation. So another side thing about statins is that sometimes, people will be put on a statin and they'll say, their numbers aren't getting better. It's because in a traditional lipid panel, which I do, but It's only because it's added on to the advanced panel where you're looking at the particles in ApoB. But if you look at an LDL-C, an LDL concentration, that also will include lipoprotein A concentration. So you can be on a statin and it's pushing down, quote, LDL, but it has no effect on LPLA. So your LDL-C is still going to look like it's high. It's somewhat falsely high because it's mostly LPA in that instance. So you really need to measure the LPA itself to know, is it affecting the LDL concentration or LDL-C. In the FORIA trial, which was looking at evolocumab, which is one of the PCSK9 inhibitors, those are the injectable medications that keep that LDL receptor out longer, it actually showed that LPLA was decreasing by about 27%. Not really clear exactly why that is, because again, like I said, statins, the main way that they work is they keep that LDL receptor out there. So there must be a different mechanism possibly that is having an effect for that. What are some other, kind of treatments? Well, in Germany, apheresis is common. Apheresis is somewhat like dialysis. They have an IV in, they take your blood, they pull out those LPA little particles, and then they put your blood back in. But within a day or two, your LPA levels start creasing back up because your liver keeps making more of these ApoA proteins sticking around the ApoB and pumps out more LPLA particles. So apheresis works, but most people are not willing to go to the facility and get it done a couple times a week, and the cost of it is prohibitive. And I personally don't know anybody who's ever had apheresis for LPLA. Unfortunately, diet and exercise really have zero effect on it. If you have a very inflammatory lifestyle, you're going to make yourself worse. So you still want to do the exercise and the healthy nutrition and deal with your stress and sleep. So you lower all the other risk factors that potentially could damage your arteries. But exercise and nutrition aren't going to have an effect on its own on LPLA lowering. Niacin, which is one of the B vitamins, it can decrease LPLA, and in some instances maybe up to 23%. But the trials did not show that if they lowered LPLA, that they lowered heart attacks, strokes, or dying, or MACE, major adverse cardiovascular events. So your numbers look prettier, but you don't have less events. So niacin, for the most part, has fallen out of favor at trying to lower LPLA because it probably just doesn't have a big enough effect. Hormone replacement therapy, estrogen, has an effect on lowering LPLA, but there's no data that you should be starting women on estrogen therapy just to be lowering LPLA. If they're on estrogen for other postmenopausal reasons and they're being monitored by a provider that knows how to do that effectively, I have no concern for women to be on hormone replacement therapy at that point, but I would not recommend people start hormone replacement therapy just to try to lower LPLA. The exciting news is that there are drugs on the horizon that will significantly lower LPLA. They've been through phase 2 trials and they're now into phase 3 trials, so they're testing them in people and trying to see, do they have less heart attacks, strokes, dying. And right now they can show that they actually significantly lower LPLA levels and generally average 80% lowering, sometimes up to 99%. Excuse me. It's a mouthful of how it does this. But these drugs are going to be called ASOs, or antisense oligonucleotides. It affects messenger RNA inside the liver. And I won't go into the exact details, but essentially this injection, which I believe is once a month, maybe it's twice a month in some protocols, but essentially will block the liver's ability to make ApoA. So you don't make that little corkscrew. If you don't have that corkscrew, you can't attach it to ApoB that's on the LDL particle. So your your LP little a numbers drop significantly. And your liver pumps out just regular LDL particles then, and you have other ways that you can treat that. Hello, Victoria. Thanks for joining. So what are some of the other things you can do to know, are you really at risk if you have LP(a)? And I should back up a little bit. Why am I interested in this? I've been checking LPLA probably since 2014, and now it's just getting more traction as something that's really driving cardiovascular risk. I actually just learned a fun fact today that Arthur Ashe was suspected to have very high levels. Arthur Ashe was a very famous tennis player, and I was really into tennis when I was younger. And I was always a little bit surprised that Arthur Ashe had heart attacks in his late 30s. And you're like, well, how would this athlete have heart attacks? Apparently, he had very high levels of LPLA. And that's one thing I didn't mention earlier is that African Americans tend to have much higher levels of LPLA than Caucasians. I don't think the exact reason is elucidated, but if somebody is African American and has had a heart attack or stroke at an earlier age, double check that they don't have high levels of LPLA. At this time, I don't think commercially there's available to know like how long the kringles are or the little corkscrews. But if you have excessively high levels of LPLA concentration, you likely have the smaller versions of the kringles. LPLA, like I said earlier, it's transporting all this oxidized trash, and it's like a dump truck. And what can you do to lower the oxidation? Well, eat in a time restricted window. Don't eat a bunch of standard American crap food. Move your body, deal with your stress, sleep. Pull down that inflammatory stress so the body doesn't damage things and oxidized LDL isn't getting made in the first place. But LPLA, has the most this one enzyme called LPPLA2. Unfortunately, it sounds exactly like LPA if you say it too fast. But LPPLA2 is an enzyme that oxidizes the phospholipids, basically causes things to rust. So there is a blood test that you can check, LPPLA2. If that's high and you have LPLA, that's like fire and gasoline. That's a big problem. So you want to try to do everything possible to lower all the other risk factors. There's another commercial lab that is doing the oxidized phospholipid on ApoB. It's a lab that if you work with me in my office, I can order for you. It's something that if you have LPLA, I'm definitely interested in getting this lab, because if you have high levels of this, you're not necessarily taking time bomb, but you're the person that you really need to be closely monitoring. So that's what I wanted to talk about tonight was LP(a). It's something that 20% of the population has. If you have a family member who's had a heart attack, stroke at an early age, such as my maternal grandmother had events in her 40s. I don't have access to any of her old records where they would have checked this, but LPLA was discovered in 1963, but I don't know commercially when people were able to start checking this. But with her events and how much stuff she had at an early age, I'm confident my grandmother had LPLA. And unfortunately, she was a smoker, and smoking basically rusts and oxidates your blood more than almost anything else. Take smoking and LPLA, that is a recipe for definite significant problems with your arterial health. So that's what I want to chat about tonight, and then I'm going to open this up to questions because I've gotten a lot of comments and feedback here. So thank you everybody for joining. Next week, I'm going to be in sunny Cancun, soaking up some light water magnetism and recharging the cellular batteries, the mitochondria. So next Monday at 6 p.m., I'll be doing Ask Me Anything. I'll probably be sitting on the beach, and I'll answer any questions about mitochondrial health or whatever else you guys want to learn about. But thanks for joining the LPLA talk, and let's open up to any questions tonight. So I did see one question about... Oh, hello, Dr. Lyon. Thanks for joining. Is higher LP(a) hereditary at all? Yes, Skip. It's all genetically predetermined. It's autosomal dominant or at least codominant. Everybody's gonna have a certain level of LP(a), but if you inherit 2 copies of the like small kringles, you have very, very high levels of LP(a). And that's why probably the most beneficial, even though this is not in the guidelines, is probably should be checking teenagers for this, because I did see some reports that by the age of 5, you're going to have whatever levels you're going to have as an adult. And it's very rare that your LPLA levels are going to change unless you're taking some type of, quote, treatment to try to affect it. If you're inflamed for some reason, yes, your levels go up. But most of the time, your levels are going to be pretty steady by the way that the liver's pumping this stuff out. So if you have high levels at the age of 5 or 6, that's somebody you need to take a look at. I have patients who are in their 60s and 70s who have LPLA that are elevated, but they have calcium scores of 0. They're not at high risk. I'm not necessarily trying to do anything else other than manage the other cardiovascular risk factors. But great question, Skip. And then Cheryl, can you reverse LPLA successfully? I'm working very hard on that one. Right now, niacin has some effect at lowering LPLA, but I don't use it routinely unless people have a lot of events, and I, just trying to throw the kitchen sink at them to try to lower their other risk factors while I'm waiting for the antisense oligonucleotides to come out. I did not talk about tonight, but there is a alternative treatment called the Pauling protocol, which is high vitamin C and lysine. There's not clinical data on this, so I don't recommend everybody rush out and start the Pauling protocol. It's something you gotta kind of do research on your own and talk to your healthcare provider and see if it's something that's reasonable for you. It's not high risk, but there's question. Are you getting a benefit of it? Was considered an early age. So for Tom, I probably would check somebody. I wouldn't check your 1-year-old for this, but it's something that and before they're a teenager, you just need to know the answer if it's normal or not normal. Question. Somebody says they have a high LPLA 57.9 in July. Question, is it the mass of the LPLA or the concentration, because they're different measurements? So is it milligrams per deciliter or is it nanomoles per liter? It makes a difference. Most of the time it's the nanomoles per liter. The concentration is the more preferred way to measure it. If you have a level over 75 or really over 125, you're much higher risk. The milligram per deciliter is kind of the old way of doing it, the mass of the LPLA. Those values are generally in the 30 to 50 range, so hard to tell exactly what that means. So what are the normal levels? I would say a nanomole per liter under 75 would be normal. And typically, if you still have an old school mass one, it's probably under 30 milligrams per deciliter. All right, I got some other questions. So somebody's saying that on their blood work they see LPPLA2 but not LPA. So if you're one of my patients, it's almost assuredly I've probably checked LPLA at least once in you. I do not check it on every lab panel. The cost of the LPLA is not great. I think it's maybe $20 even through the big commercial carriers. But if it's something that was in the normal range once, there's no reason to keep repeating LPLA to see if you have it. It's not going to be elevated. But if it's something anybody ever wants me to check and I haven't checked it, I'm more than happy to check it for you. Question, what is an early age for a relative having heart issues? Generally in the 40s, especially if it's a woman. Women tend to have heart disease about 10 years older than men, mainly because estrogen is cardioprotective. But if somebody's having, a heart attack, stroke in their 40s or early 50s, you need to at least rule out high LPLA. And that's something that, I did, in 3 years of cardiovascular training, I never heard of LPLA. And we'd have these people come back, with recurrent stent thrombosis, or I should say in-stent restenosis. It wasn't stent thrombosis, that's a different pathophysiology, or they'd have bypass grafts that were clogging back up full of gruel. Very likely it's the LPLA that's driving that. And so unfortunately, maybe it's not that you have a great treatment options for you, but those are the people that you need to put an eye on more frequently and look at all their other risk factors and try to fix as much as you can fix for them. All right, we've got some great questions coming in tonight. Is there anything else I can answer about LPLA or cardiovascular disease? There's a question, Is this what causes cardiac events in marathon runners? Not necessarily. A lot of times the marathon runners, it's a overtraining where to improve their cardiac output, their stroke volume increases. So essentially their heart chambers expand, so more blood gets squeezed out with each heartbeat. And that kind of stretches out the wiring system in the heart and also causes some micro scar tissue. And that's probably one of the major things that causes cardiac events in marathon runners, especially like atrial fibrillation. But if they're also overtraining and not recovering, then they can have high inflammation. And then that high inflammation is basically scratching up the arteries. And if they don't recover, then plaque will start developing. Question, does this have anything to do with factor V? Not exactly, but if you have factor V Leiden, which is or factor V Leiden deficiency, and you're more likely to clot because of that, and you have Lp(a), that's synergistic. You're much more likely to clot. So those are people that aspirin therapy is probably more beneficial for. The Pauling protocol, it's vitamin C and lysine. I can't prescribe medications or supplements via the internet. If you're very interested in a detailed review of that, there are videos online that explain it, or you can work with me in my practice, Apollo Cardiology. So somebody's saying, do I follow Dr. Tom Dayspring's work? Yes, of course I do. Lipidoc on Twitter and LinkedIn. I listened to his 8-hour podcast with Dr. Peter Attia. I listened to it twice in the past 6 months. Dr. Dayspring's one of the world's experts in lipidology. The treatments on the horizon it's the antisense oligonucleotides. That's the main one. There's another one that a different company is making that essentially does something a little bit different. It just basically prevents the LDL particles from getting made in the first place. It doesn't attack the kringles that the antisense oligonucleotides do. But I don't know exactly if they have a trade name just yet. I know they're just in phase 3 trials. All right. And somebody's saying, are there other treatments that lower Lp(a)? You'd have to type them in. I don't know exactly which ones you're mentioning. Oh, that's great. Yeah. There's a really good Dr. Dayspring one they just did like last month, and it was like a hour and 20-minute one, so kind of compressed like in the past years, what are the big updates in lipidology. That 8-hour one is like if you're just a really big science geek and want to know the nuts and bolts of lipidology. So treatments, the vitamin C is part of the Pauling protocol. So, vitamin C by itself is not likely to lower Lp(a). It may block the binding sites for Lp(a). That's the background theory of the Pauling protocol. But to get the exact doses, you have to work with a healthcare provider that knows how to do that. All right, you're welcome. Thank you for watching tonight. Thank you for asking good questions. All right, well, I want to respect everybody's time. I usually kind of cap these off at 30 minutes. But next week, like I said, it's going to be all about light water magnetism and optimizing your mitochondria by soaking up some sun and some electrons from earthing and grounding. The best way to contact me in the interim is through Instagram. I'm pretty active here daily. If you're in St. Louis and want to work with me, I'm at Apollo Cardiology. My main website is drtwyman.com. And I'll see you guys next week. Have a good evening.